So our next speaker is Dr. Soumya Ganesh, who is a consultant and medical director of Lopamudra Drishti Eye Hospital, Kurg, Karnataka. She is a prolific cataract and refractive surgeon and has numerous international awards to her name. Dr. Soumya, are you there?
Yes, I'm here. I'm here. Am I audible?
Yes, yes.
And is my screen visible?
Yes.
Yes.
Is it?
Yes.
Yes, we can see.
Visible. Thank you. So at the outset, I thank ARC, Dr. Harshul, Dr. Chitra for having me as part of this session. This is a case of a myopic eye with mature cataract. And what I'm going to show you in this case in the end is basically a PC plaque peeling. But also, I'd like to take this opportunity to give a few points on operating on a mature cataract itself. So the first thing is, of course, the capsule has to be stained well and uniformly to be able to get a good rhexis. And on doing the rhexis in a mature cataract, it's very important for us to grasp and re-grasp at the edge time and again to make sure we don't have a runoff. And it's very important to start with a slightly smaller rhexis area and then enlarge it for it to become a sufficiently large rhexis. And if needed, it would be a good idea to change hands or change sides also to make sure the rhexis is optimal. So this, like we all know, is the first step and most basic step of doing our surgery. So now that the rhexis is completed, the phaco, of course, was quite routine because it's not a very hard mature cataract. So a routine phaco and the phaco was completed. And in some mature cataracts, quite often we don't have a lot of cortical matter, not a traditional cortical matter, but we may have some amount of adherent cortical matter, which is actually more of a challenge in doing a cortical wash. So like you can see, it's not the loose cortex that we see in most of our cases, and this is mostly adherent to the posterior capsule. So it is still very important to do a good cortical wash to make sure all the remaining cortex is removed, and to be very careful in not damaging the posterior capsule while doing this cortical cleaning. So if you can notice the posterior capsule at this point, apart from the cortex that we have, there is also a grayish plaque on the in the visual axis of the posterior capsule. And so this posterior plaque might quite often bring down that wow factor that we get after surgery. Of course, there is an option to YAG it. But again, a secondary procedure immediately after the phaco, again, there is some explaining to do. So now, like you can see, the cortex aspiration is done, and what is left is the big plaque or the thick plaque on the posterior capsule. If this was more outside the visual axis, probably one could still leave it, but since it's right there, probably it's best to be removed. So now the AC is again inflated with visco, and then a small cleavage plane is made with the spatula. Like you can see, we got a small cleavage plane. One can also make this cleavage plane with visco itself, but then it might be a little more challenging. And now that we have this cleavage plane and we have the plaque that has come up, one can use a microrhexis forceps to just peel off the plaque and clear the posterior capsule, and basically, most importantly, the visual axis. So you can see there is still some adherent plaque remaining, but this was there is no cleavage plane that we could just kind of lift it up with. And since it's anyway not in the visual axis, sometimes it can just best be left alone. So now that the visual axis is clear, one can just go ahead with implanting an IOL, followed by a good wash. Thank you. The rest of it is just implanting the IOL, so I'm going to let it go.
So,
Yes, Harshal.
Yeah, so that was very nice, Dr. Soumya, the way you peeled it off. Another small trick which helps, I'm sure you must have tried that. If you take your irrigation cannula and go from main incision, and you try to just, put the direction to a posterior capsule, it also separates the plaque, and you find a good cleavage pen and you can separate it. it just works like a hose pipe, no? So that also works well.
But I have a thought here. Of course,
Yes,
one
ma'am.
other thing in the beginning, in these into total intermittent high myopic cataract, maybe you should actually do a smaller excess and do an IA and decompress the bag and then go on to enlarge the excess. But you've done
But
that
that
well.
was not an intumescent, ma'am. It was,
Yeah.
of course, white cataract, but not typical intumescent that it will go away. So she made a perfect rexis in one go. That was good. Yeah.
But PC plaques are not very common in high myope unless they've had a history of a silicone oil surgery. I mean, vitrectomy and a silicone oil. So I wanted to ask, maybe Partha, I'll ask, if in this case of PC plaque, if she could not have found a cleavage plane, could PCC have been tried in that case?
Yes, Chitra, very important and a very pertinent question. So the first, if the plaque, and she lifted it so well, if that edge of the plaque comes off, then you know that you can peel it, number one. But if the edge of the plaque is not forthcoming and you have a clear-cut plaque with a clear-cut margin, then it is a good technique to go around the plaque and do a PCC. And it works very well with a proper viscoelastic in the anterior chamber. It is easy and much easier than when we are dealing with the posterior, dealing with the posterior capsular rexis in a pediatric cataract. In a pediatric cataract, it's very elastic and the vector forces are much different. Whereas in a senile cataract, these are much different and easier to perform. So that would be the next technique. The third technique, which I have at times resorted to also, is to place the IOL inside the bag and then go through with an MVR knife into the thick plaque, and then with the vitrector carve out a central opening into the plaque. So that also works well, and especially if it is a large plaque where you cannot actually take it round the rexis without endangering the whole PC getting ruptured. So these are three techniques that can usually be followed.
Because this was a high myope or just myope anyway. So opening the PC would, always have more chances of disturbing the posterior segment. And as it is, these cases are more prone to detachment. So I think it was lucky, or it was good for Soumya that, that plaque came out.
I agree. 100% I agree. Yes. Dr. Mido, I wanted one question from you before we go on to our next speaker. In a high myope, and there is a possibility of a posterior staphyloma, when you do biometry, what are the formulas which you would consider?
As Dr. Ramurthy said, we are totally into Barrett Universal 2. We have been getting quite good results. Only thing is, patient, we have to see posterior segment properly, see whether there is a staphyloma involving the macula. Then we have to tell the technician properly that they have to take it repeatedly, repeated machines. We do it in 3 machines actually, and then repeatedly get the same kind of value and then make sure. But the formula is Barrett Universal 2.
Dr. Kamal, do you have anything different to suggest?
Yeah, I would agree with what Dr. Partho said. Number one, what Harshul said, I've been doing it for ages. I've also got some videos on YouTube doing that. I call it jet polishing. A 27 gauge cannula with a spiral lip bent, an angle of irrigation hitting at 30 degrees. You will automatically find a cleavage plane between the plaque and the PC. So that's one idea. Second idea, what Dr. Partho said was, I do it a lot of times. If I'm not able to get the complete plaque off, I do put an IOL on top, and I use the same trick of, cutting it with a Rex's needle instead of using a MVR. I might just cut a little nick with a Rex's needle and go in from a side port with a 23 gauge cutter and cut my whole capsule. And the easiest, simplest thing is to put your IOL, leave it there, and go live another day to do a yak cap slot in that. So all 3 work.
Yes, thank you very much.